Hello and welcome, everyone. Thank you for joining us this evening. I'm McKenna Campbell. I'm your host. Before this awesome presentation gets going, I do want to share a little bit about the association, and then we'll get into the foundations of psychedelic medicine. Let's see. So ACS is an international association of healthcare professionals on the forefront of cannabinoid medicine. Founded by physicians, ACS is uniquely positioned to advocate for the highest standards in the practice of cannabis medicine. We are an advocacy organization striving to guide lawmakers and regulators at every level of cannabis control. We also prioritize inclusivity and value having members from all walks of life, which motivates us to provide discounted memberships to qualifying groups, as you can see here. In addition to these discounts, student memberships are also free. Please reach out to us directly if you have any concerns about how you can get involved. On this next slide, you can see that there are many benefits to joining ACS. For all of ACS's constituents, we provide evidence and experience-based education to support the premise that cannabis should be treated as a medicine. Please feel welcome to reach out to us with any questions about membership. For our student leaders, we encourage you to learn more about our Student Ambassador program. While we work to ensure that we can provide free and discounted opportunities when we can, ACS is still a nonprofit organization, and so we do rely on donations. We appreciate any level of giving, and you can support us directly through the QR code or website link as listed on the slide. Kelsey, maybe you could put that link in the chat so we all have access in case anyone is super ready. And now I have the distinct pleasure of introducing you to tonight's presenter. Dr. Eugene Vortsman brings a comprehensive understanding of substance use disorders and harm reduction strategies to his role as a prominent figure in addiction medicine. Beyond his expertise in addiction treatment and emergent pain management, Dr. Vortsman is also deeply engaged in psychedelic education and harm reduction initiatives. Recognizing the growing interest in psychedelic-assisted therapies for mental health conditions, Dr. Vortsman advocates for evidence-based practices and safe integration of these treatments into clinical settings. He is committed to promoting a compassionate and non-judgmental approach to substance use, whether it involves cannabis, psychedelics, or other substances, and actively works to reduce stigma surrounding these topics. As a leader in both addiction medicine and psychedelic education, Dr. Vortsman continues to drive forward the conversation on holistic approaches to healthcare and the importance of harm reduction in medical practice. And with that, I will pass it on to you, Dr. Vortsman. Thank you so much for joining us tonight.
I don't know who wrote that introduction, but I appreciate it for saying it. Thanks, McKenna. I'm gonna start sharing. Okay, I'm gonna start sharing my screen. Welcome, everybody. Thank you for taking the time to listen. I know this is not a typical ACS lecture, but considering what we're dealing with here and how we're just trying to expand the mind and look for every opportunity to help, I'm excited to speak about this. So to start off, title, Foundation of Psychedelic Medicine, Clinical Perspective. My name is Dr. Vortsman, as McKenna spoke about. I'm gonna start there. So just a title, just a little bit about me, a little more, I guess. Clinical Director of Addiction Medicine, Disease Management. Sorry for the ambulance. I do live in New York City, so it's constant background. Chair of the Pain Committee here at Long Island Jewish for Northwell. Co-chair of Substance Abuse and Pain Advisory, associate professor, and I'm dual board certified in emergency medicine and addiction medicine, where we hope to be able to manage acute care, acute addiction, acute pain, and final alternative approaches to pain management. Disclosures: I sit on an advisory board for a kind of a respiratory opiate overdose reversal agent, so we're hopeful that we'll be able to find other modalities to help our patients. Some learning objectives for today: we're going to be learning foundations of psychedelic medicine, understand the fundamentals of natural and synthetic psychedelics, understand essential up-to-date chemical effects of the most common psychedelics, learn current FDA-approved studies and the potential impact, and better understand the current landscape of the commercial use of psychedelics. And a common theme I always say here, and I say the same thing with cannabis, is that there is so much opportunity for this to help. I don't think there's a cure-all for any of this, and there's obviously significant potential benefit, significant potential harm, and we just want to be able to ask the right questions and get the right answers. So to dive in, what are psychedelics? They start off as a class of drugs that cause the person to experience hallucinations or change their perceived reality as a class. They make a person see, hear, or feel. The root of the word actually is between psyche and delos, right? To show the soul. And there really is no other class of drugs that has a similar kind of title. To look into the soul, to look into the mind, and see a different perspective. So psychedelics can both be natural or synthetics. Some that people may know, natural, things like psilocybin, peyote, San Pedro. ayahuasca, and some synthetic options, ketamine, LSD, MDMA, MDA, synthetic DMT. Some of these things are becoming very mainstream these days as we continue to look for solutions for the continuing opiate crisis, our mental health crisis, and also, fortunately, unfortunately, very frequently associated as a club drug and with raves. So a little bit of history, pleasant surprises. By the way, we do have a small group today, so feel free to ask any questions in the chat, and we can talk about it, try to answer it, or we'll address everything at the end. So some pleasant surprises. Dr. Hoffman was the LSD discovery, initially utilized as a respiratory stimulant, but found to not be very effective. This is 1943, where he had his first accidental hit of LSD that was like shelved prior. And he kind of described this as the April 19th, right? It's bicycle day, the accidental dose as he rode home. And this happened recently enough that he was able to even share this experience on video, hear his real voice, and hear about his real experience. And the way he kind of describes it is initially terrifying, but shortly after giving way to a feeling of clarity and well-being. And then shortly after, his assistant, Susie Ramsey, became the first woman to accidentally take LSD as well. I really do love this picture. He's working for a pharmaceutical company named Sandoz, bicycle day. This is from a TV show on Netflix called How to Change Your Mind by Michael Pollan. He also wrote a book, I'm sorry. It's a book, and that's on Netflix as well. Really highly recommend. Just do a little quick intro. The way his initial description, these are his. I can watch that for a long time. But it really brings up a very common experience. Can be sometimes overwhelming. Why, again, it's so important to ever, when we do move forward with this, to have proper therapy, proper preparation, a very scary beginning. But really, it sounds like a very beautiful conclusion if done correctly with the right prep. Some people would describe it as a breakdown between the gates of your senses, right? So to be able to, see, smell, and taste color and that kind of experience. And become kind of this opportunity. So then became this future, one with your patient. And then this guy, it created this new word, one of my new favorite words, a psychotomimetic. I work in the emergency department, very busy, large tertiary hospital. We have a huge behavioral health area, huge psych area. And then there's this idea of psychotomimetic. It mimics the experience or feeling of psychosis, experience the thought process for acute mania. And so you had them, basically Sandoz distributed Delcid. And I hate to read from slides, but I think it's an important kind of summarizes. By taking Delcid, LSD himself, the psychiatrist is able to gain an insight into the world of ideas and sensations of mental patients. Delcid can also be used to induce model psychosis of short duration in normal subjects, thus facilitating studies in the pathogenesis of mental disease. The way they describe it is that the therapists themselves can either better understand their patient by having an acute, reversible psychotic experience or a psychotomimetic, right? Never heard of something like that, right? Something where the people wanted to better understand their patient, better be able to relate to their patient, and then be able to have access to such a medicine that was, overall very, very safe in regards to hemodynamic stability and, how your blood pressure and your heart rate and oxygen level would manage. So this new thing opened up a whole new world of experimentation. You had a global boom of research between 1947 and 70s. They said, if you have any idea of a research project, they were sending you LSD to your research lab, to your quote unquote research lab. 40,000 patients were enrolled in over 1,000 studies. And they did some incredible research where they evaluated LSD for treatment for alcoholism in the 50s and 60s, or alcohol use disorder, as we say now, shortened duration of psychotherapy, right, to really be able to get in touch and access those inner deep feelings, repressed memories, improved mood disorders in 80% of patients. But this was early days of research, so we can't really use a lot of that data because it was subpar standards, right? No diagnostic techniques standardized across the system, like scoring systems the way we have now. No pre-intervention of symptom severity. And there was really not a significant lack of randomization and control, also known as a lot of room for improvement. And then the Controlled Substances Act started in 1970 and basically placed LSD as a Schedule I drug. If anyone here is not fully aware what a Schedule I drug is, basically says that a Schedule I drug has high potential of abuse and no potential medical benefit. Put that in perspective, cannabis at this point on a national level is still a Schedule I drug. And as we know, especially from people in this group and a lot of amazing research and researchers, we know that cannabis does have utility, while it does also have potential for addiction. Um, and so that's an important thing. And a lot of it basically just completely stopped all the research that was going on. You had the Journal of Psychedelics, um, and it really just took a hard stop to everything. It had to do in a big way. Popular, unpopular opinion in regards to the war on drugs was a, kind of against things like the Black Panthers or against the anti-war hippies, to basically disrupt those communities, which is why things like cannabis and LSD became illegal, disrupt the communities, disrupt the leadership, and really stop them in their feet. So that's a little bit of the history. So we learned about it. We want to talk about it's time to use it. So we're going to focus on 6 psychedelics that have become mainstream: psilocybin, ketamine, LSD, MDMA, DMT, and Ibogaine. Not to say these are mainstream, but they are becoming more mainstream. And I think that you're seeing these on headlines and research projects and finding that we have never seen before. So why so trippy? Bro, there's a lot of significant overlap in how most of the psychedelics work. In general, excluding ketamine, they are serotonergic. So they hit the receptors in general in the prefrontal cortex. That part of your brain is your mood and your cognition, perception, how you see the world around you, how your general demeanor is. And it impacts something called your default mode network, your salience and executive networks. Again, kind of connecting parts of your brain that really weren't there before. I think I do enlarge this picture, but I kind of love it. These are fMRI images in the bottom right, shows how your brain is generally connected with the placebo on the left of that picture. And then what happens for a lasting, persistent connections found almost up to a month after dosing with psilocybin, how you have these new connections. Um, and I'm actually going to take this opportunity. There's something called the stoned ape theory. Another talk I do is about the cultural history of psychedelics and how it's been part of our society and shamanism. And we see paintings and cave paintings of mushroom-like things and gods and tons of ceremonies. And they talk about the stoned ape theory has to do with the fact that why did the Homo sapiens or so beat out the Neanderthals? And there's a lot of good theories that say that's possible because as we were being nomadic, the Neanderthals were much bigger than us, stronger than us, etc. That the Homo sapiens were able to, they ingested some of these placebo, these mushrooms, these psilocybin, and made connections and were able to create tools and understand how to utilize their environment in a better way. As theories go, I find it to be an interesting one with some really amazing literature behind it. To go back to a little bit more of the scientific. So as it increases the connections across your brain, you have that agreeability saying, hey, these are new ways for me to grow and change. And when we consider things like neuroconnectivity, we talk about how these exposures lead to new connections, increased synaptogenesis, neurogenesis, and that increased creativity. Michael Pollan describes it often as, if your mind and your thought process is generally in certain snow, like and you're skiing in certain ski tracks, it's kind of like a fresh layer of snow, right? It doesn't mean you won't go down those tracks, but it does give you an opportunity to make new tracks, to have new ways to process the world around you. So we're going to dive into again psilocybin. Psilocybin is an inactive ingredient converted to a very potent psilocin. And that's dried mushrooms in the bottom right of that image. Serotonin receptors said to actually be stronger than serotonin itself. A lot of it shows that initial research of psilocybin and mushrooms was actually what led to our current most common usage of SSRIs in regards to selective serotonin reuptake inhibitors or as an antidepressant. And there's other names for this, as we know: magic mushrooms, shrooms, mushies, often seen used by various indigenous communities. To highlight one is the Mazatec region of Mexico, and they call it Niños Sagrados. Other names just shows their status in the community. And when I talk about SSRIs, while they are very helpful for many, many people, we do continue to have a mental health crisis in this country. We do continue to show that, SSRIs really only work for about 60%, 50 to 60% of people who take it. And that's after about 2 weeks to 4 weeks of taking it. And truthfully, the way I view it is that while psilocybin and these other drugs these other medicines might not be the cure, there are very few medicines I give people in the emergency department or in addiction care really that only work 50% of the time. And so there's something important to say, this might not be the answer, but it's important to discuss it. So some common side effects when taken at higher doses, they're very, there could be mild to very profound changes. Obviously, potency is a very important factor here. And we talk about changes in sensory perception, synesthesia, where you can kind of see colors associated with numbers and letters, euphoria, sensory illusions, auditory visual hallucinations, again, kind of going back to the psychotomimetic. These effects in general last about 4 to 7 hours. Obviously, as Dr. Hoffman highlighted, some unpleasant feelings that sometimes patients will express that when they're in that bad place, they have a fear or an anxiety that it's an unending experience that will never end, as well as nausea, vomiting. Some people have some very significant headaches. The mushrooms here are non-dry in this image. As we kind of highlighted, some of these slides will present out the PDF, but we want to just kind of highlight, you do have some visceral reactions, dilated pupils, difficult to concentrate, but some more positive things like a sense of peace, spiritual awakening, newfound perspective on life. A pretty interesting side effect of a medicine, I'll say. Negative nausea, vomiting, but the derealization, depersonalization, the dissolution of ego are all potentials. Paranoid confusion for sure. Heightened fear responsive, disturbing imagery can be very, very scary, very uncomfortable for many patients. I'm going to take a second, see if there's any questions right now. How to change your mind. Yay, bicycle day. There are 13 strains of magic mushrooms. Generally, it's potency is what it is. Obviously, don't go picking mushrooms off the ground. Be very, very dangerous. As they say, there are only, what do they say? There are young, brave mushroom pickers or old, wise mushroom pickers, but no old, brave mushroom pickers. Generally has to do with the strain. Okay, back to it. So psilocybin mechanism of action, serotonergic, binds to various receptors. So I'll leave a little cute little happy face. So kind of repeating, decreased blood flow, right? When neuroimaging has been performed before and after, highlight, right? This isn't just an experience that happens while you're quote unquote high, right? This isn't just like similar to morphine and pain. Morphine, when I give it to a patient, generally works during that acute state versus if they have a broken bone, morphine helps with the pain, fixing the bone actually fixes the problem. So here you have decreased blood flow to the default node network, kind of dissolves, they call it ego dissolving, salience, executive function, that increased connectivity in areas that weren't connected. Like I just love that image from before. Less emotionally avoidant. So the the patient feels more open to discuss the things that are really holding them back in their life. Increased cognitive function due to that neuroplasticity and improved depression symptoms. And some stories you read about, you see these podcasts and conventions, the increased cognitive function, for example, people will talk about the fact that it's actually a intracellular serotonin agonism. It's not extracellular. They've been able to do that. So once you get the medicine to go in, you have a neuroplasticity, synaptogenesis, etc. And there's potentially a future speaker for us here with ACS, but people who enroll in these studies will say improvement in depression symptoms. They feel improvement in their depression symptoms before the experience is even over, where their Montgomery scales for depression are down to 0 is what some people will say, and last and persist, right? SSRIs work for many people, don't work for many people. Psilocybin, while it might not be a cure, it really has an opportunity to help them get into a good place, help them get to, fix the problems that have been going on and go from there. Neuroimaging consistent to after 1 month after dosage, and we don't see that with SSRIs. Sorry, I just really love this picture. I think it's also a beautiful piece of art, so I thought it's important. Neuroconnectivity, exposure directly leads to new connections. So I like to take a second. And I think there are not many medicines I get to do for treatment have this kind of effect. It looks to me like the brain just coming alive. So we're in a new age right now at this point. You have NIH funding, almost $22 million, grant opportunities for the study of psychedelic assisted therapy for relief of chronic pain, for example, right? So this is important. It's never just the psychedelic, it's psychedelic assisted therapy. Therapy is the key and fundamental thing that has to be maintained as we move into this new kind of frontier. But it's psychedelic assisted, right? That openness, that empathy, that, in that way, and hopefully be able to also manage a lot of chronic pain. So psilocybin study trials that are actively going on right now, major depressive disorder, fibromyalgia, alcohol use disorder, substance disorder. We're going to go into a little bit of this, phantom limb pain, anorexia nervosa, PTSD, and many, many more. And so these are trials. Again, people are asking the right questions. We're hoping to get the right answers. This is a very, very busy slide, but we're not going to go through all of it. But I want to highlight that people are showing rapid and enduring improvements after psilocybin. As you can imagine, it's a little hard to do a placebo to a psychedelic. So they do their kind of best to things like Versed or is basically niacin for like the flush, but very, very difficult. And that's a lot of why some of the delays in the medical community uptaking it, because it's really hard to do a randomized controlled study, which is obviously consistently our best standard of research. Depressive symptoms reduced in 1 week, 6-month follow-up. The changes were sustained at 80% of participants and at 51, right? We don't have large, but things are moving in the right direction. Enduring anxiolytic and antidepressant effects, anxiolytic being breaking down that anxiety people feel, clinically significant reductions. This is an amazing study. This was done at NYU for alcohol use disorder. They gave 2 doses of psilocybin, split up by 2 weeks with standard therapy. And they had an 83% reduction in heavy drinking days for up to 8 months after exposure, right? These are not numbers I know of in the addiction world to be so effective, right? So half of all psilocybin equals no drinking, and they had no drinking at all up to 8 months later, right? Again, some of the limitations continue to be, the N is fairly low, 95 people initially randomized, but really compared to the standard of care, huge difference. And again, 2 psilocybin experiments, as long as you're in a controlled therapeutic environment with a sitter, generally speaking, very safe medicine. And we know that there's a lot of things, potential SSRIs, etc. How am I doing on time? I am 8:30. Okay, great. Migraines, something very important we talk about. This isn't just mental health. These are true disabling things that if you've spoken to anybody with chronic recurrent migraines, they cannot function their life. They explored for after 2 weeks after reduced migraines 50% in intensity and their functional disability, and had to reduce the number of attacks per week. This is where they evaluated the trial of psilocybin versus citalopram for depression, right? So this was shown to be a non-inferiority study, right? So imagine 2 experiences of psilocybin that work relatively immediately compared to the need to taper or titrate up citalopram for depressive symptoms. So this was a phase 2 double-blind trial, N of almost 60, moderate, severe, major depressive disorder, change in scores that lasted and persisted up to 6 weeks. These are not people who are doing mushrooms or shroomies every day. This is 2 experiences, again, with therapy, guided in a safe environment. There's a question in the chat. Can patients go to specific clinics for these therapies without enrolling in study? Absolutely not. Unfortunately, Sangeeta, at this point, it is only research based, specifically for psilocybin, especially there are ketamine, but that we have not got into just yet, but we'll get into that in a second. When they talk about no significant difference between psilocybin and citalopram, really interesting is that those are the primary outcomes, talked about their depression scales. The secondary outcomes, on the other hand, in regards to outlook on life and kind of more difficult things to objectively measure, were significantly better with psilocybin. They felt, these patients who are suffering with major depressive disorder, finally felt that there was a possible light at the end of the tunnel, right? An opportunity to be better. So, wow, right? Non-inferiority, and again, this is when we talk about almost immediate efficacy in regards to change of baseline. Continues a single dose of psilocybin for treatment-resistant depression. MADRS scores, which is the depression scales, with an N of 233, again, shown to be a non-inferiority in their primary outcome. Let's do with it. Adverse events of psilocybin, dose-dependent in general. Headaches, nausea, and dizziness. Higher the dose, the higher these side effects. But these are transient and reversible without any need for intervention or not a large amount of like hospital visits and no admissions, no need for aggressive intervention. So this slide, I do love this slide. It kind of goes back to what we talk about, but when we talk about, this was in a journal that's way above my own understanding or pay grade, but using very advanced kind of imaging modalities, they basically plotted out patients' brain flows in regards to depression, where they have these very deep peaks and valleys in regards to their mental state. And psilocybin was shown to kind of flatten out those peaks and valleys in regards to ability to change how you're viewing the world. And then what happens after that, while it doesn't necessarily, again, there's no cure, you can see in the post-treatment persistent improvement of their symptoms, right? More of a flattening out, still have those volleys and troughs, but way less intense than what you see on the before treatment. I just think it's a great, really beautiful image. Yeah, exactly. Agreed. It just kind of makes it feel a little more real, which I really appreciate about it. I had the privilege of working with some people who are huge advocates for cluster headache community. Cluster headaches, for people also known as suicide headaches, not amazing studies, but kind of like self-report in a lot of ways, use psilocybin, reductions in almost 60%. People who use LSD is effective for 88%. Another survey, almost 500 sufferers. Cluster headaches are suicide headaches. They come on seasonally or stress related. You can have sniffles in the nose, and you have these kind of like, it feels like you're having a needle isn't enough, like an arrow in your brain. Really, really dysfunctional studies. And so another sort of 500 people are using psilocybin, LSD, and DMT for treating that. So again, really, really exciting potential. We're going to transition a little bit. This is a different psychedelic than psilocybin in its modality and how it works. It was synthesized in 1965. Atypical because non-serotonergic. It's an NMDA antagonist. It's a dissociative anesthetic. I use it in the emergency department for three big reasons. One is for intubation. So when people are very ill, but their blood pressure is low or etc., I can give them a proper dose and they'll will go to sleep more or less for me to do the procedure. It's also very useful for pain management. And also we use it for mild sedation when I need to, pop a shoulder back in place, or we use it for children actually when we got to take that marble out of their nose. We got a suture. It's very, very safe. So it's a dissociation, hallucinogenic properties, and also very profound antidepressants. I think this is the one and only branded picture I have here, but Spravato was the only FDA approved antidepressant called S-ketamine. It's basically generally ketamine is utilized the way I use it, at least, and the way you'll generally see it in ketamine clinics is racemic ketamine, so S and R ketamine. This is for major depressive disorder, FDA approved as an intranasal, and it's really opened up a whole new world of ketamine clinics. And so in this subgroup, this is the medicine that you can utilize for major depressive disorder in various clinics. But I would very much, be cautious about the level and quality of the facility you go to. And I won't personally, I don't get any money or anything from any of them, but there are definitely some that have a much higher standard of proper care and preparation, and do something that's very important in ketamine and all psychedelics, which is called the set and setting, really able to help you in a big way. Ketamine is even utilized as an essential medicine on the World Health Organization, but this is the first FDA approval for a mental health disease utilizing a psychedelic. So that's really an exciting kind of neat future. Of course. So some deep dive into the ketamine mechanism of action. Works on glutamate receptors as part of the NMDA antagonism. I'm not going to go too crazy, but this is your regular mood, synaptic homeostasis. And then you start having, with depression, you have a destabilization and how those neurotransmitters will go across your synapses, and how those like kind of brain receptors and brain chemicals will communicate with each other. The ketamine comes in as like a burst, very rapid. You start having synaptogenesis and kind of bring you back to homeostasis. So current ketamine studies are fibromyalgia, major depressive disorder, and CRPS, which is chronic regional pain syndrome. I'll dive into it superficially, but quickly. Fibromyalgia, widespread musculoskeletal pain, fatigue, memory, mood issues. Obviously, having chronic pain really changes so many people. And so looking for any potential solution to help these patients who are suffering will be huge. 95% of the patients tend to be women, shown to be lists of symptoms based on different body systems. Oral psilocybin is also being utilized for chronic pain in these patients. Similarly found to have neural connections change in default mode network. Psychedelics are known to downregulate chronic regional pain syndrome. 200,000 Americans annually, again, generally women, but not as much, not 95%, generally women in their 40s, and they actually have physical alterations. Not fibromyalgia generally is kind of more, I don't want to call them subjective symptoms by no means. They're truly suffering but it's much more harder to visually assess it. With chronic regional pain syndrome, CRPS, you can literally see swelling and skin changes, texture of the skin. And ketamine at 0.35 milligrams as a drip, the dosage is pretty wild. It's for 4 hours at sub-dissociative dosing for 10 days per day. So found to have an improvement of symptoms for up to 3 months. And so this isn't exactly a solution, but this is, again, asking those right questions. When I'm putting someone to sleep for a procedure, I'm usually giving 1 milligram per kilogram. So this is a significant reduction to their general dosing. Actively right now, we have 37 active trials, at least. And then this is just from the last time I did this, but this continues to grow. Things like chronic migraines, chemotherapy, neuropathy, painful limb ischemia, phantom limb, which is really amazing. Again, usually associated with a therapy, but understanding postherpetic neuralgia, that has to do with neuropathy. Trigeminal neuralgia, if you've known anybody with trigeminal neuralgia, which is when you have nerve pain across your face, these are also considered to be, it's called another suicide disease, because it's chronic, unrelenting, truly people who are suffering. So we're going to change ship a little bit. We're going to talk about MDMA and LSD. There's overlap, so we're going to kind of bundle them together. Similar mechanisms, both increase your neurotransmitters, serotonin, dopamine, and norepinephrine. Large increases in the serotonin, influences your mood, feelings of love, trust, sexual arousal, increase your oxytocin. Anyone's ever seen, let's say, this is considered MDMA here, often seen as a capsule, but not always. As a powder, is considered to be Molly, lasts about 3 to 6 hours. Significant upper, huge serotonin, huge oxytocin, kind of feel very much in love with the world, is what people say. It's why it's often utilized in raves and concerts and festivals. Also often utilized for couples therapy in this world, usually in the underground world, and we hope to be able to, kind of bring it out into the light so that it can be done properly and safely. LSD is generally a blotter paper. Compared to MDMA, 3 to 6 hours, LSD is almost 12 hours, so much longer experience. Some of the history of MDMA versus LSD, similar to what we talked about with Dr. Hoffman, but and Sandoz, MDMA patented in Merck as an appetite suppressant. Definitely do not eat too much when you're on MDMA. Advocate as an adjunct for openness during that golden era of psychedelic research, so to speak. I'd argue maybe we're in the golden era right now, as well as more funding and availability. It was made illegal in 1985, became a designer drug in the 80s. New nickname of ecstasy, became Schedule 1 by 1986. I'll say, as a kid who grew up in Brooklyn, New York City, and early to late 90s, there was a lot of ecstasy going on, especially my ex-Soviet community. A lot of people like just going to raves and staying up all night and that kind of thing, but it was became much changed up. LSD, similarly discovered by Dr. Hoffman for the respiratory stimulant in 48. Sorry. It was introduced as a cure-all, right? And I'm going to keep reiterating there is no cure-all for anything. And introduced as a cure-all for multiple mental health diseases, and then it started appearing on the black market. Tim Leary was a huge advocate, a huge speaker for it. He was a psychotherapist at Harvard. He stated that one session with LSD was better than years of therapy with a therapist. He kind of was, a big advocate. He usually thought LSD should be in the water and we would fix all the world's problems. Unfortunately, he had a little bit too friendly of relations with a couple of students at Harvard and got kicked out, quote unquote, possibly for the advocacy of the drug use. And by 1967, became seen as a part of the anti-war counterculture for Vietnam. I was banned in the United States. I'm going to take one more second. Any questions right now? Okay. So MDMA, positive and negative effects. Described healthy volunteers utilizing MDMA, right? Kind of more in the phase 2. Euphoria, empathy, connection and pathogens is what it's often called. And then pathogen, it generates empathy, insightfulness, extroversion, positive mood, feelings of authenticity, just being your authentic self, interpersonal trust and compassion. Most common in the clinical population is anxiety, and if not done correctly, and access to painful emotions that can lead you to be in a much worse place after your experience. Again, very heavy slide. I just want to highlight MDMA being used with therapy is very key, and it continues to be utilized. Significant reduction in PTSD, huge reduction in PTSD. Again, no longer met criteria for PTSD, right? After their experience with MDMA, they didn't meet criteria as a PTSD patient. I think that's something really amazing, something really incredible. So, unfortunately, as MDMA stands out as a significant neurotoxin, major study, I think it was in Nedrum published, effective MDMA through blood flow, axonal damage from calcium toxicity. You see this very obviously in these pictures. Highest dose, you have a lot less of the brain matter in the highest dose versus the lowest dose. It's like, oh, wait, hold on. It was completely retracted because they actually used meth instead of MDMA, and had to retract the study. And again, same thing here, rat hippocampus, which is like your memories and processing of memories, compared to the serotonin receptors on the left with MDMA versus control. And it's like, look at that, it was terrible. Oh, wait, same study, same people used meth instead of MDMA. That's usually my ringer. That's my funny part of the talk, because when I was prepping this, I found it to be ridiculous. Phase 3 study, PTSD, MDMA, sponsored by an organization called MAPS, the Multidisciplinary Approach to Psychedelic Studies. I think now they're called Axios, so they just recently changed. MDMA-assisted psychotherapy for severe PTSD, randomized, double-blinded, placebo-controlled phase 3 study. So in regards to Roman's question about serotonin syndrome, generally speaking, the serotonin syndrome is overall very rare and much more common with serotonin SSRIs. And this is actually not so much increasing the serotonin as much as it is an agonist to the receptors themselves, versus things like serotonin syndrome, which unfortunately you have to always check for in the emergency department, which only has to do with poor metabolism of the serotonin itself, as well as eating foods with a high amount of tyramine, like cheeses, etc. Great question, though. So this is a already published study. This was published in Nature magazine. Showed compared to first completed, phase 2 trial. Wait, sorry, 1 second. That was weird. Phase 3 trial, psychedelics for PTSD. All of our favorite words, right? A randomized, double-blind, placebo-controlled phase 3 study. When you compare the results, treated PTSD with MDMA-assisted therapy. Again, I'm always going to emphasize MDMA-assisted therapy, always with therapy. Compared to regular results, you had almost a third of improvement of symptoms into standard therapy. With MDMA, you had 67% of people who lost their PTSD diagnosis, and then you had almost 21% more that had a clinically meaningful response, and 12% with no response, compared to 38% with no response in non-MDMA assisted therapy. The transient negative effects of MDMA they found was transient hypertension. That second M is a methylate group, so there is a significant stimulant, but these were temporary and reversible with no adverse events reported. Almost N of 90 randomized, show significant reduction almost immediately with exposure. Effect size of MDMA assisted compared to regular was significantly improved. And so a few things are clear. More research is needed, but the people are ready. When we keep talking about some how ineffective SRIs are, obviously you see a significant improvement here. And some of these trials, I do need to confess, have gotten under certain lights. They had some inappropriate relations between therapists, again, kind of unfortunately with the empathy, etc. And MAPS is back to not so much the drawing board. They recently had a huge upset with regards to FDA approval, but it wasn't a complete reboot. They did their best to address it, but very difficult to create a placebo effect and truly say that the MDMA was not partially placebo. But to be honest with you, based on the number of patients I'm seeing, and I think the country is seeing in regards to depression, PTSD, especially our military veterans, even if it is placebo effect, I'll be honest with you, I'll take it. That's the truth. Some extra amazing work that's been done with ketamine, 96-hour continuous for treatment-resistant depression. You can see decreased blood flow with the default mode network. That's your DMT, not the drug, but the area of your brain, the connectivity across your brain with these prolonged infusions. And what's important to highlight on the left in that kind of complicated swivel of lines is that most of the effect was seen in the first 5 days, right? Dose-dependent improvement of depression scales in the first 5 days, not in the latter. And so that's really amazing. People are going through some very severe levels of depression. This is an immediate effect. And even some of the pharmaceutical companies are looking into saying, we have a boarding issue, which boarding means patients who sit in the emergency department or in our emergent psych areas without a bed. Unfortunately, we suffer, honestly, with keeping people in hallways for days on end, especially psychiatric patients. And so there's this idea that if you're able to get a truly clinically significant improvement in these scales within the first 24 hours, 36 hours, you really can get people to safely get discharged, safely follow up with the therapist, and maybe avoid an admission and/or really continue their therapy outpatient. IV ketamine therapy for major depressive, strong evidence supports utility. Again, if you look at this as a multiple various studies with fairly reasonable ends, you see that all the studies show some improvement of symptoms, all leading to the right with clinically significant differences. This on here looks like a fairly standard ketamine clinic, kind of sterile, unfortunately. It doesn't really provide the good setting, but calm environment, eye mask, ears covered, blood pressure monitor to make sure your blood pressure doesn't go too high. And you get frequent check-ins by a physician or any kind of provider or a nurse, or even a therapist that's properly trained. Ketamine treatment resistant, you can see again, they tried to do a placebo with Versed, Versed versus ketamine. You can see a significantly dose-dependent improvement in symptoms with ketamine at 0.5 milligrams per kilogram. Remembering that when I put people to sleep, it's a 1 milligram per kilogram. So these are considered to be sub-dissociative dosing. So under dosing for a dissociation for ketamine. Evidence for strong improvement, often seen on day one. I will have to highlight that here, it's important. I think it's my last slide on ketamine specifically. Unfortunately, there's some significantly bad press with Matthew Perry, who unfortunately passed away using ketamine. Proper person, the right place, again, set and setting is so important to highlight. Unfortunately, Matthew Perry was using ketamine in a hot tub. And if you've ever seen anyone use ketamine, if you work in an emergency department, an operating room, ketamine kind of separates your brain from your body in a way. And unfortunately, that's most likely what happened with Matthew Perry. Exactly. He K-hold. K-hold is where people take too much. You can see it with their eyeballs. Often their eyeballs are kind of, it's called rotary nystagmus, rolling very fast. And his body was not, so to speak, was not his, which is why proper environment and safety really shows how important this could be and how it can help so many people. But when it's abused, it really gives it a really bad look. Psychedelic publications, you saw in 1960s, obviously major reduction in studies, and we're already seeing it get much better. 2020, not our best year for research publications or funding, but I think everyone knows why, but we do continue to go up. Let me transition a little bit here. DMT has been looked at right now for as an anti-inflammatory effect. Sometimes, oh shoot, not 850. I'm going to go back. I'm going to speed up a little bit. Giving myself a headache here. Anyway, DMT has been shown as being looked at for potential to treat for strokes, considering that some of the trauma post-stroke has to do with the inflammation. Often these days heard of as ayahuasca and as Costa Rican and Jamaican and Mexican environments where tourists go and have these experiences. The active ingredient is DMT. Really some really amazing potential work here. The treatments that I have for stroke are very, very limited. Oh, and one final thing about DMT, which to show, I think, at least the least amount of respect towards shamanism and stuff like that, is that when people intake regular DMT from the ayahuasca root, your MOAs, your monoamino oxidases in your stomach actually inactivate DMT, but they've been able to find the other roots and other plants MOA inhibitors that you get taken together. So they figured out that naturally through, I don't know, experimentation or otherwise, that to keep the DMT active, they found other roots and other natural plants that worked as MOAs, which is what used to be the standard for as antidepressants before SSRIs came out. So I found that to be very fascinating. This is gonna be the last one. Iboga and Ibogaine, really interesting, really amazing work, and a lot of unknown here. Similar and it's serotonergic MDA antagonist, also shown to be effective at mu and kappa mu receptors, or the opiate receptors, often utilized with medicine for pain, codeine, morphine, and unfortunately, as well as with heroin and fentanyl. SRIs uptake inhibitors really increase all those numbers. What's cool about it, so the experience itself, acute phase lasts for about 4 to 8 hours. You do have these hallucinations, often described through like closed eyes. They feel like they have hallucinations, unsteady gait, they're not walking well, nausea, vomiting. And then you have a post 4 to 8 hour post acute phase, reflective, calm, that ataxia, unsteady gait, those tremors are kind of over, and they reflect on the imagery seen during acute phase. If you ever watch these testimonials, Ibogaine is illegal pretty much only in the United States, and it's legal everywhere else. There's some really amazing clinics that are doing good work and helping people with various things. But they basically, some people will say they feel like they're seeing a movie of their life and they're able to reflect on it. Derived from the roots of an Iboga plant tree, and found in Gabon, Africa, in Western Africa. Various indigenous tribes. Unfortunately, of course, being over harvested and exploited by Western kind of bioculture is now a risk. But here, like all these different utilities for Ibogaine have been really amazing. Opiate use disorder. People will say they report a reduction in opiate withdrawal symptoms, 50% decrease in cravings, 25% decrease cravings for up to 3 months. So basically, people will say that they can, so to speak, snort their last line of heroin and go into an Iboga experience and skip the dope stick, skip the withdrawal. And if anyone here has ever taken care of patients who are suffering with addiction, they're not really getting high. Many people are not really getting high anymore in a big way. A lot of them are just, they're scared of dope sick and they don't want to go through that withdrawal. It's really an incredibly terrible experience. And so here Iboga has been, and they don't know why yet, as far as I can find, but it's been able to completely skip that phase and help them. Also shown to be helped with symptoms of PTSD and MDD and anxiety. There are some veteran organizations that will send American vets abroad to other countries to get this experience to help them with their PTSD or their addiction they may have developed, or the substance use disorder they may have developed due to their PTSD or their depression. One exposure showed abstinence from cocaine for over 5 months, multiple exposures for 8.5 months. And if done properly, unfortunately, Ibogaine is considered, I'll get to that in a second. Ibogaine plus magnesium special ops decrease their disability, PTSD, depression, anxiety. Unfortunately, no randomized controlled studies. It is considered to be at this point the most dangerous of the psychedelics. Several direct sudden deaths associated with it. Has to do with arrhythmias. It's partially a sodium channel blockade. There's also long QT syndrome, but honestly, as somebody who works in the emergency department, every medicine is a long QT syndrome. It has to do with EKG and how their EKG is how their heart and electricity is flowing in their heart. They can also have a slow heart rate and low blood pressure, as well as some potential harm in their cerebellum. That's Ibogaine. Some upcoming research projects, all phase 2. MAPS is doing multiple association psychedelic studies, PTSD, anxiety. This one's a really interesting one too, social anxiety and autism. The empathogenic aspect of psychedelics are shown to kind of be that where they feel a bigger desire to connect with people. Often people with autism suffer from having difficulty from understanding nuance or connections or emotional expressions. And so that's been amazing. Compass is doing phase 3 psilocybin studies for treatment-resistant depression, LSD studies for migraines, anxiety, ADHD, Ibogaine for opiate use disorder, MDMA for alcohol use disorder. Not trying to highlight anything, but there are already public companies doing amazing research, creating great communities, helping people get access to some of these medicines. Ketamine at this point are probably your safest bet, I would say, and most accessible at this point. Tripping is going mainstream. How to Change Your Mind by Michael Pollan. Really interesting watch. Pharmacopoeia is by this guy named Hamilton, who is a pharmacist, and he goes on, it's on Vice, I think it is, and he goes on, just tries pretty much uses his own body as his own temple, so to speak, and experiments with a lot of different drugs. Don't recommend that, but it is very interesting to watch and go through the experiences and describe it at a kind of advanced level. You know, the FDA is moving towards approving it. It's one of the, you know, it's being studied at Hopkins and Columbia, NYU, major centers. This is one of the few, I think, bipartisan issues which are going on right now. The VA and, you know, we're losing so many soldiers and vets to suicide that I think that anything that could help, I'm excited about. These are my citations, and any questions, I guess the line, once we start to better understand the past, better we can make the future together. That is my email address. Feel free to email me as I'd like. I'm going to stop sharing. I'm sorry that took the whole hour. I am annoyed at my own voice. Thank you so much. I gave myself a headache. And any questions, feel free.
I do want to add in, please don't be annoyed at your own voice. I don't think anyone here is, and that was really great and really insightful. So thank you so much.
I'm just kidding. You know, a little self-deprecating humor goes a long way. Glad you enjoyed, Jared. I do, yes. So in regards to kratom, I wouldn't consider that to be a psychedelic, to be honest with you. I do know a decent amount of kratom. Unfortunately, kratom also has its own potential for mu and opiate overdose. Uh, if you look on Reddit and opiate, and there's a fairly supportive community using kratom to help with withdrawal symptoms, but it also can be addictive, also causes really severe gastritis and stomach pain, very irritating. And it does help some people with anxiety as long as you don't, you know, keep it in check. Again, the problem with a lot of these kind of bodega deli stuff is the purity of these substances, which is a big issue with a lot of this stuff. But kratom, I think, is very interesting potential for opiate treatment, opiate withdrawal. I don't think that methadone is it, to be honest with you, which is why my initial interest and excitement about the potential of psychedelics and cannabis, which also very much can be under the umbrella. But kratom is, you know, again, dope sick and withdrawal of just these people. I see them daily. I mean, they're suffering. And so anything that helps, I'm for, as long as it's done correctly and safely with regulation. Cool.
All right. Well, if there's no other questions, it is 8:59, right? So right almost 9 on the dot. Definitely, yes, we definitely need more research. Thank you, Roman, for sure. Yeah, if anyone else has any questions, feel free to take that last minute. Otherwise, thank you all for coming. Really appreciate it. Hope to see you at all of our ACS events. And again, thank you, Dr. Vortsman, so much. Super insightful. Really appreciate your time.
My pleasure. Nice, sir. Thanks for coming by.